Okay, great. This is Aidan Raney with MD. We're excited to have Andrei Pop on today. He is the System Structural Director for Ascension, Illinois, here to talk to us about unicorn and some other alternatives to basilica. Go ahead, Andrei.
Hey, Aidan. So nice to be here and talk about this. This has been quite a project for us over the last 9 months or so. We started uh, we just had a patient that needed help, and we were aware of the technique, and we decided that we should try it. And since then, we've done 6 cases, and I think we have 3 more in the pipeline. So basically, this is where it all started. The unicorn procedure was reported by a center in Hong Kong. Basically, the idea it's a leaflet modification where instead of cutting the leaflet with electrosurgery, you make a hole in the leaflet, you enlarge the hole, and then you put your valve through the hole. It's basically a way to, let's say, more completely obliterate the leaflet rather than creating a simple cut. So if you want, it's balloon-assisted basilica on steroids.
Yep.
Why unicorn versus basilica? To me, it's less steps. It makes a bigger defect in the leaflet. Um, you can get away with a single access femoral. It's faster, and it is available now, whereas the off-the-shelf leaflet modification techniques are down the pipe. Um, it's done. We've done it mostly with Sentinel. Cleveland does their alternative technique that we're going to touch about later. Um, Purely with Sentinel. Our first 2 cases were without Sentinel and we had no problems. We always protect the target vessel. We put the TAVR sheath in. We engage the leaflet similar to basilica. We cross with a J-tip VersaCross, and I'll talk about that later. We exchange for a Safari. We balloon the leaflet with a 3 millimeter and then a 10 or a 12 millimeter balloon. You put the valve through the hole in the leaflet, and then you do balloon valve fracture at the end. Or at least you do post-dilation of the valve to make sure it's well expanded.
Hmm.
Um, these are the VersaCross wires that are available. This is not playing the way it's supposed to play. The most important part is that you really want the long VersaCross wire, and those are the SKU codes that you would use to get the long J-tip VersaCross wire. If you get the pigtail wire that you see on the left side of the screen, the tip is too strong and it deflects the tip of your crossing system. So we've had situations where we didn't have the right wire and then we kind of straightened the pigtail, but we really prefer the J wire. It works best. And if you have a 230 centimeter J wire, your life is going to be a lot easier.
And again, Andrei,
Um,
you said that's
yeah.
because the pigtail shaped wire is you said it's too stiff compared to the.
It basically you're using the same setup as you would use for a basilica. So you're going in with a AL or a AL1, AL2 catheter. Let's say for the left leaflet, you put a support catheter through it, or a like a Bernstein, something that allows you to have a little bit more tip deflection. And then when you come in with that big pigtail, that pigtail basically moves the entire contraption. So you've put it
I
in
see.
place, it's sitting in the right center of the leaflet, then you advance the wire and the whole thing moves away.
It moves
So
away. Got
you really want something that's relatively straight. And even on the J wire, sometimes we straighten it. So this is a unicorn example, 74-year-old guy, STS prom was 20, had a 23 Magna Ace before, had moderate severe PPM post-implant with a mean gradient of 22 at baseline right after the surgical valve, morbidly obese, end-stage renal disease, all sorts of bad stuff. Left main height was 2 millimeters.
it.
This is his anatomy. On this measurement, I got 3 millimeters, big difference. Um, as you can see, we lined up the valve perfectly on CT, but then when we got to the cath lab, we discovered that his defibrillator has actually overlaid the perfect
Oh,
angle. So then we had to use a bastardized angle to find the crossing position. Um, Similar to basilica, basically 2 positions. One is en face and one is on profile. In profile, so you're trying to find the bottom of the leaflet, And obviously, if you have a externally mounted leaflet like in trifecta, it's a lot more difficult. For a internally mounted leaflet, you have a little bit of a gutter at the bottom of the leaflet where it meets the ring, and you go right into that gutter, and from that gutter you perforate into the LV outflow tract, ideally. Um, this I'm not sure it's gonna play, but it's not playing, of course. But basically, once we crossed the leaflet, we advanced support catheter in the ventricle. We then put a safari wire in the ventricle. You see the protection is in place. We ballooned with a 3 millimeter balloon, then we ballooned with a 12 millimeter balloon, and then we deployed the valve through the leaflet. Again, all of these should play, but they don't. I'll be happy to upload my slide set to Murmur, so you can download and play with it.
Awesome. Real
Once
quick,
we,
Andre, so your
yeah,
setup again, you're using a 7 French guide
uh-huh,
with,
a short guide.
oh, it has to be short. Okay.
Yeah, I prefer a 90 centimeter guide. I generally use a 7 French AL1 or AL2 for the left. And
Okay.
through it, you either put an 035 support catheter, I prefer the CXI,
Yep.
or you put a Bernstein.
Okay.
The If you put the Bernstein through the 7 French guide, you don't really need a copilot on the end of the guide because there's no room between the two catheters, and
Sure.
basically it's not going to bleed back. And then through that, you put the radio frequency wire, the VersaCross wire, and basically that's all. You do it exactly like you'd find a basilica. So it's the same steps that you would use for crossing the basilica. The only difference is that here you're crossing with the 035, and in a basilica you're crossing with the 114. In this case, we re-engage the coronary at the end to show that we're really we did the proper damage, and we had no trouble re-engaging through the frame. You can see we're all the way in. Ignore that black line. That was a mark on the screen of the monitor that I used. I really wish that this would play, but anyway, the mean gradient in this case was 8 millimeters of mercury invasively and 5 millimeters mercury on echo, which
Wow.
is, again, the patient started with 22 millimeters of mercury after the surgical valve. So with the unicorn and a balloon valve fracture, we actually lowered the gradient compared to the baseline after surgery. These are some other examples where, again, when the images will play, you'll see much better that you can actually see the movement of the leaflet. This is a very reasonably calcified leaflet, and you can see the movement. The leaflet basically lifts up and down your guiding catheter that's sitting on it. So what about the pitfalls? Valve crossing can sometimes be difficult. There's a theoretical risk of asymmetrical leaflet tear. There is a risk of a hemodynamic instability. If that occurs, you just need to pace the patient a bit faster because you're causing wide open AI. There is a risk of stroke. We haven't had any strokes in 6 cases. The Cleveland guys haven't had any strokes either. And at least theoretically, there may actually be a benefit in reducing the risk of stroke because of the way the procedure is done. Just remember that neither successful unicorn nor successful basilica eliminates the need for protection, especially if you're using a sapien, and some people have used evolutes in these as well. There is a risk that the post of the new valve sits in front of the cut that you've created. And that's more of a problem with basilica. With unicorn, obviously, the leaflet is essentially completely removed and the risk should be lower, but we always protect. Protection is so easy, it doesn't hurt.
What about
This
the
is,
risk of
yeah.
the asymmetrical tear, and you know, when would you know that? Anything you can do about? Because you're just going to be deploying the valve, right?
Right. So the tear can happen in the Cleveland paper. They saw no tears in aortic position. They used the same technique in mitral position, and in mitral they've seen some situations where
Mm.
the leaflet tore completely before the valve went in. So just with a balloon. In our experience, we've seen a fair amount of complete tears before the valve went in. And that may be related to the fact that a lot of the valves that we dealt with were trifectas and they were very small. So, when you're using a 12 millimeter balloon in a 19 or 21 trifecta, that balloon is bigger than the leaflet, than the length of the leaflet, so you're going to tear it. And there is a theoretical risk that that tear will not be symmetrical, that more of the leaflet will go to one side. And in the Cleveland paper that I'm going to quote later, they actually have a case where they see the leaflet peaking above the frame of the old valve. So the tear was such that the leaflet was just able to move a little bit higher. In our experience, we had one guy where we saw the leaflet right in front of the left main. And even though the patient had good flow, we elected to stent just to be on the safe side. And I think that's why protection remains important, and doing an IVUS at the end is very important, and we do that in all cases. So these are our experience, six cases so far, average STS prom almost 12, average age 76, 4 trifectas. I don't think trifecta has been reported in the literature yet. 1 Magna A's, 1 Epic, 5 left mains, 1 RCA, and case duration 1 to 2 hours. The cleave is the Cleveland technique that is essentially very similar. You see the illustration at the end with the virgin trapping the unicorn, and the guy comes and kills it. I like the unicorn rather than than the cleave name. The difference with the technique from Cleveland is that they use a variety of wires, 014, 018, 035. They use off-the-shelf equipment plus cautery, whereas in the proper unicorn technique, you use 035 VersaCross from Boston Scientific. And the cleave has been applied in both aortic and mitral, whereas unicorn has really been described for aortic. The other highlight of the Cleveland paper, in my experience, in my opinion, is that they actually have benchtop models where they did this in collaboration with Stephanie Seller's group from Vancouver. And you can see on their aortic cleave, they actually had a complete rupture of the leaflet with a balloon. On the mitral, just the leaflet enlarged before the valve went in. The other thing that they highlight on the left side of the screen at the bottom is that the leaflet is completely gone. The leaflet is just not there anymore because it's completely pushed to the other side. So they speculate that basically based on that, the next time you come around to do a valve in valve in valve, you have a lot more room to do another cut, whereas with with a simple basilica, you have just a slit right down the middle. So I think it's a good technique. It's been applied in surgical valves. It's been applied in TAVR valves. Most of the experience, I think, is with putting sapiens in. There is another named technique where you put Medtronics in. It has a funny name which escapes me right now, but it's in the references that I had before. And this is just, unicorn saving the day. This was from the New York Times 3 years ago about the little kid who floated out at sea and on their inflatable unicorn. So this is all I had. I had somewhere in here a step-by-step that I seem to have passed by. Yeah, so this is the step-by-step. I don't think that I have all the equipment listed in here, but basically 7 French 90 centimeter guide, some sort of catheter in there that reduces everything to 035. You lay the guide on the leaflet, you advance the microcatheter to the leaflet, then you advance the tip of the VersaCross wire and you make a simple cut and you're in the ventricle.
That's great. So, a couple questions. How much of the VersaCross are you sticking out? Just a millimeter, 2 millimeters outside?
No, I mean the nice thing about the VersaCross, and let me see if I can maybe share my proper slides and maybe it plays on my proper slides. So I'm taking. Let me take off these slides and see if I can figure out how to do it. But basically, the moment it crosses, I generally use the 2-second cut. The moment you cross with a J wire, you see the J tip forming in the ventricle, in the LV outflow tract. The moment the J tip has formed, you stop, right? And with a 2-second cut, the moment you're across, the J tip forms. And then you stop cutting, and then you just push the wire in the ventricle. It finds the apex. You go to an RAO view. And then you advance your 035 support catheter. And once that is far enough in the ventricle, you just go with a Safari.
Okay, and that's a good question too, because 2 seconds is a pretty long cut. I had this issue I think once with a transeptal for a clip where we're trying to get extremely posterior inferior, and it may have hit the back wall. So I'm always very careful just to burn and then push. But here, do you need to put some forward pressure and kind of push a little bit as
Yeah,
you go across, or do you
yeah.
just
I
wait?
mean, we started with 1 second cut. You can certainly do it with a 1 second cut. We found that 2 second works better in our experience. You obviously want to be very careful. If that wire starts moving places where you don't like it, you definitely don't want to go there. The other thing that I think is important is that we had one case where the wire went, we felt it went in the ventricle, and the our echo guy basically said, I can't see it.
Hmm.
Another difference is we do the aortics under general anesthesia with TE. Cleveland has done theirs under conscious sedation. Um, this case was really, eye-opening for me because the wire felt funky. It wasn't moving properly. It wasn't certainly not going for the apex, and TE couldn't see it. So I said, you know what? Either this wire has perforated somewhere. Obviously, that was a post-surgical patient, so that was relatively safe. Or it's in a good position, but it's just beat up and it's not behaving properly. Either way, we have to kind of do something different. So what I did is I basically buttressed the guide as hard as I could against the leaflet. I pushed on the support catheter again as hard as I could to keep it in place. I removed the wire. I figured the worst penalty for removing the wire is I lose the position and I have to do another crossing. And then I took just a standard long J wire and I pushed it in. And by the grace of God, basically the 035 support catheter kept its position against the hole. The J wire went into the LV outflow tract. The TE dude saw it instantly, and then the J wire found the apex. And I think the idea is the VersaCross. It's not the world's friendliest wire, right? I mean, it's a relatively stiff wire. The tip is relatively short, the flexible portion. So the point of the VersaCross is really just to make a hole, and after that you can switch to something else. What's interesting in the Cleve paper from Cleveland, they actually use 014, 018, or off-the-shelf 035 wires. So technically, you can just use an off-the-shelf 035 wire, and then you electrify the end of it. So that's another option for us. The VersaCross works really well, and we're happy to use it. But we always exchange it once we get in the ventricle.
Yeah, that makes a lot of sense. And I think, to me, it makes sense to use T in these cases too. Just why not? More information, the better.
Yeah, and I mean, these are not the cases where you want to do minimalistic TAVR, right? I mean, these cases, we're doing 200 plus cases a year, and we're doing maybe one a month of these. This is not to where you want to cut corners because especially if you're doing a TAV in TAV with this, and you have a virgin chest, and then you make a hole somewhere where you shouldn't, you're going to be in a world of pain.
Sure, absolutely. Great. Well, Andre, that was super helpful. Did you have anything else?
Okay, well, let me do the meaningful portions here.
Perfect.
So this is where you see the crossing. See, the moment the wire jade up in the ventricle, at that point you're essentially done with the radio frequency.
And I
Boom,
can't
you're
see your
done.
microcatheter there, but I think I see your 7 French sheath, right?
Well, the microcatheter is really, in this case, I think we use the Bernstein. That's why you can't see it.
It's all the way.
But basically, it's not radio opaque. Um, this is where you see, we put the 035 CXI in the ventricle and we advance the Safari through it. Then we verified our position on the coronary protection. Here you see the inflation of the 12 millimeter balloon, or a 10 maybe in this case. Here you see the valve deployment, and the hallmark of a unicorn where the leaflet hasn't broken is exactly this tentative movement, kind of halfway through the inflation, the valve is restrained and then all of a sudden it jumps to the other side. If the leaflet
Amazing.
has moved, if the leaflet has ruptured, you know that because during the ballooning, the balloon moves from here, all of a sudden self-centers in the middle of the valve. And if the balloon moved
Mm.
out of the side to the center, you ruptured the leaflet with the balloon. Again, that didn't happen in the Cleveland experience, but it happened several times in our experience with the trifectas especially. And
So
here
two
you
questions.
see
Oh yeah, go
post-dilation.
ahead. And then post dilate. So go back one. You said you check, you take a shot through the guide, through the coronary guide after you've done
Uh,
this.
at the end, I do. So let me show you that. So
But after you've deployed the sapien valve, you
after
don't
you
know.
deploy the valves, yeah.
Okay.
Yeah, this picture that we had, let me see. This is the balloon valve fracture. This is really at the end. But right here, we're just making sure that everything is good. You know, the coronary protection is in place. We advanced our microcath, I mean, guide extension in the coronary. We're
Yep.
preparing to do the thing, to do the deed. So the stent is going to go in the coronary. Everything is going to be ready as if we're going to protect or deploy.
Okay.
And then at the end, I think very importantly, you re-engage the coronary and you verify that
Um,
you're not behind the frame, but rather that you've truly opened the access. So this is after we took out the protection and we re-engaged the coronary.
gotcha. One other question we talked about this, I think, before. I still haven't done any of these, but I think before you were talking about doing it, and the size of the balloons. I think initially it was like they'd used a real small balloon. It was like, well, why not use
Yeah.
a bigger one? And any thoughts on that?
So we
Upsizing.
I think when you use an 035 wire, the smallest 035 balloon that you can get in long shaft is a 3 millimeter balloon.
Okay.
And in our experience, that goes through a 7 French and it crosses well. If it doesn't cross well, then you have to take a CXI or something and push it in the ventricle. Because, for instance, the Bernstein doesn't have a very good crossing profile. In some cases it goes, but the 035 CXI definitely is a more friendly crossing catheter. But in our experience, once you've crossed with the CXI, you exchange for a Safari, then you should be able relatively easily to introduce your 3 millimeter balloon. You dilate with that. Once you've dilated with a 3, then the 12 or 10 can go. We started
Sure.
with a 10 and we moved to a 12. I would say that it's prudent to look at the size of the valve, right? So if you're doing this for a 25 millimeter valve,
Go bigger.
then a 10 probably will not rupture the leaflet. A 12 might. If you're doing this with a 19 millimeter valve, a 12 will definitely rupture the leaflet. So it's kind of dealer's choice. The reason we moved to 12 is early in our experience, we had some cases where even though the leaflet had been dilated with a 12, we just had difficulty advancing the sapien across. And we had to move it around a bit, flex, extend, rotate this, that, and the other. And it felt more trouble than it should have been, considering we had a big hole in the leaflet. So that's when we moved to a 12 millimeter balloon. In the last 3 cases, I think we haven't had any of that. But I don't know if it was a function of the fact that we started with trifectas or why that happened. But that's kind of what led us to move from the 10 to the 12.
Awesome. Great. All right, Andre. Well, we really appreciate you going through all this stuff. I have not had a case that, luckily, that I've needed to, but I know I'll get one soon. So I'll be reaching out to you, and really appreciate the tips and tricks here.
Yeah. No, thank you. And I think this whole thing kind of highlights the power of murmur because, I recently had somebody call me not 10 days ago and say, "Hey, how do you do this?" We
Sure.
walked through it. We talked about the equipment. He actually found that the J-tip wire was available in 230 because we only had on the shelf 180 and we felt that it was all that was available. And it really highlights the power of murmur. And I think
Yep.
anybody who wants to do this, I'm available. Give me a buzz. We'll talk you through it.
Awesome. All right, Andre, thanks again.
Thank you. Take care.